Good morning, everybody. This is Justin Dunaway with the Institute of Clinical Excellence, and coming at you live from Portland, Oregon, this beautiful, not sunrise yet morning. Today I want to talk about a really cool paper that came out exploring directional preference in a high psychosocial risk population. But real quick first, for everybody who's coming down to Vegas this weekend for the annual Institute of Clinical Excellence Sampler Seminar, I just can't wait to see you guys down there, and I am beyond excited to be there this weekend and hang out with all the faculty from ICE. So it's going to be a really cool show. If you guys are coming down, can't wait to see you. So let's get into the paper. So this paper came out this year. It's called Directional Preference and Functional Outcomes Among Subjects Classified as High Psychosocial Risk Using Start Back. And I'll post this in the notes. But what they did is they took 138 patients with back pain and back-related leg pain, and then that classified as high risk on the Start Back tool. If you guys aren't familiar with the Start Back tool, it's a really quick questionnaire that's designed to classify patients as low, medium, or high risk for developing disability within 6 months. So then you're supposed to take these classifications, and then you can have targets or treatments targeted to each specific demographic. So if you're classified as high risk for disability based on the Start Back, the protocol is a psychosocially or psychologically informed physical therapy to address symptoms, functions, psychosocial obstacles, a cognitive behavioral therapy approach, maybe a multidisciplinary approach pulling in other professions, but it's going to be more based on changing the yellow flags, a solid centrally dominant type approach. Now what they did is they had 138 patients that were high risk on the Start Back with back pain, back-related leg pain, and then they evaluated them for directional preference, so sort of a McKenzie approach, right? And they found that within that group, 65% had a directional preference. So then they divided them into two groups, the directional preference group and the non-directional preference group. And both groups got the same kind of standardized education, which was designed to empower the patient to be actively involved in their treatment, to reduce fear and movement intolerance. And then if you were in the directional preference group, you got exercises based on your directional preference. So if I had back pain, back-related leg pain to my heel, and I did some repeated extensions, and it centralized the pain a bit, then I had an extension-based program, vice versa. If you didn't have a directional preference, then you just got sort of an active rehab program. And then they used the one of the functional status outcome back scores from the photo, and they found that the directional preference, or both groups, did pretty well. They had significantly important changes, but the directional preference group outperformed the non-directional preference group, and they did pretty darn well. Why this is an important paper is that it's really easy for us to get in the habit of pigeonholing patients. You know, you especially into this centrally dominant psychosocial category, right? You do your evaluation, you come back, you get your paperwork, and they score pretty poorly on the Start Back, or they have a poor or Barrow score, or pain catastrophizing, or kinesiophobia scale, or whatever your yellow flag measure was. When that comes back negative, it's easy for us to kind of get in the habit of saying, okay, this is a centrally dominant patient, let's dive right into the prefrontal cortex, we're gonna throw all this education at him and really dive deep into that. But it may not be appropriate on the front end for all patients, or it may not be the place to start. What this paper shows us is that even with a high psychosocial profile, if you can centralize their pain through repeated movement, sustained posture, shift correction stuff, that's a great place to start. Because guys, and don't get me wrong, yellow flag stuff is important, and we've got to be able to change these things. But if I'm going to get to a position where you trust me enough that I can change your beliefs, a really great inroad to that place is symptom modification. If you walk in the door with lots of yellow flags and raging leg pain, and I address your beliefs about pain day one, you may not be buying what I'm selling as strongly as if when you walked into the doorway day one with lots of maladaptive beliefs and raging leg pain, and we could change your raging leg pain first. Then you're thinking, okay, this person knows what they're talking about. This is my guy. Now I'm a little bit more amenable to some of the stuff he's saying. So if we can move the symptoms day one or early on, it develops, I earn a lot of capital that I can then spend on changing beliefs and expectations. Another important thing that fell out of this paper is this piece. There was a really high dropout rate, about 21%. So 21% of the patients here dropped out, and the dropouts were more likely to not have a directional preference, were likely to be more chronic, using pain medications, and be in physical therapy longer. So what this cohort tells us, and they didn't dive deep into this, but what this tells me is that these patients, most likely, the most dominant feature of their pain day one probably wasn't the leg pain. There was probably something else going on. And by doing just this targeted physical activity approach, we may not have been addressing the most dominant features of their pain, right? So, with these patients, they may have been a little bit more classically centrally dominant. Maybe diving in and talking about pain day one with them may have been more important. Maybe finding ways to calm down the nervous system day one and just changing the symptoms a little bit with maybe some deep breathing techniques, or maybe they were maybe they weren't driven by prefrontal cortex stuff. Maybe they were neuroplastic type patients. So maybe getting in and looking at pain pressure thresholds and 2-point discrimination and laterality, and then having some treatments designed around those things day one to move the needle might have been our inroad a little bit more appropriate than what was done with the group that dropped out. So the key, guys, is not pigeonholing your patient based on one or two things, but really listening to your patient, watching them move, understanding their symptom behavior, and developing a hypothesis that encompasses the most dominant features of their pain experience, and then designing a treatment around changing that pain experience. Yellow flags are important. They're incredibly important, because they are some of the predictors for driving acute pain to chronic pain. They're going to exacerbate future pain. They're going to have some pretty serious negative downstream effects. And when we identify these things, we've got to be in a position where we can change them. When we identify negative expectations and maladaptive beliefs, we have to go after these things, and we have to be able to change them. But we may not be able to attack those things day one. They may not be the most dominant feature of the patient walking through the door. And it's okay to meet the patient where they are, identify the things that we can change the most early on, attack those, and then start sprinkling in our psychologically informed practice, our graded exposure, our things that are going to change our maladaptive beliefs and negative expectations. So maybe this patient that walks in the door with the high psychosocial profile, the radiating leg pain, that absolutely needs some beliefs and expectations, maybe the place to start with them is going to be calm down their leg pain. Get them on our side. Get them to relax. Give them some hope and show them that they have the ability to change. And now we're going to start feeding them the stuff to change their beliefs, to change their expectation. We're going to de-educate the fear. We're going to de-educate the lack of hope and the learned hopelessness first. And then once they're on board there, we're going to start to rebuild the resiliency through our education and through our changes in the yellow flags. At the end of the day, we've got to understand that the experience of pain is complex. It's multifactorial. It's hard to classify. All domains of the painful experience have overlap. And they're going to change and they're going to shift. And the things that are most important day one, week 3, may not be the most important things to changing the patient's experience at week 4, week 5, week 6. We've got to always be paying attention to our patient as a whole. Always have our thumb on the pulse of what the most important and changeable features of their painful experience is, and then be willing to shift when the patient shifts. When we're in clinic, let's just make sure that we're not pigeonholing our patients and diving into one singular approach for the patient that walks through the door, especially the ones that we're starting to see some of these yellow flags, maladaptive beliefs, negative expectations that may be classified as more centrally dominant pain. Let's not throw all our eggs in that basket. Let's really pay attention to our patient as a whole, find the things that we can change, make changes, and then drive the patient forward. Cool. That's all I got for today. I will post that article in there. It's a pretty interesting article. Lots of good stuff, lots of bad stuff. But just remember that it serves as a beautiful reminder that that there's more to the patient than the questionnaire that they filled out. If you have any questions, post them below. And for those of you that are coming to Vegas this weekend, can't wait to see you. Have an awesome night, day, morning. Sun's still down.